This week on the BackTable podcast.
Even yesterday, I did a case where I was a little bit deceived by the rug, and it turned out to basically be a short membranous stricture in a heavy guy. You know, BMI probably like 38 or something. Maybe that's for you guys. Like,
yeah, in Ohio, I'd love some 38s.
Teasing. But yeah, so like all of a sudden we're in there and he's youngish, and so his good vasculature, it's not, dry. And all of a sudden you're like, okay, we're doing a case here. And it wasn't exactly the case that I had envisioned. And so if you don't have exposure to that, if you don't have the experience, I think sometimes that kind of thing could be hard for someone in practice to manage that or even want to manage that.
Welcome to BackTable Urology, everyone. I'm George Koch from The Ohio State University, and I'm really excited today to introduce Dr. Ben Breyer from the University of California, San Francisco, to discuss kind of all things urethral reconstruction. Dr. Breyer, thank you so much for taking the time to speak with us today.
George, thanks for having me.
Before we get into urethral reconstruction specifically, I was wondering if you could tell me a little bit about your path to becoming a reconstructive urologist.
Yeah, I think I was really fortunate to be a resident at UCSF where Jack McAninch had his practice. He's, one of the seminal figures in the field. And it wasn't clear to me that I was going to do female urology. And it's a love story. It turned out that the person who's now my wife and I were dating, and I didn't want to do a long distance relationship. So I kind of removed female urology from the table, but I've always kind of been interested in quality of life and quality of life surgeries. And I think that, and then the creativity that's associated with reconstructive urology, those were the things I think that drew me to the field. And then having Dr. McAninch have a willingness to take me on as a fellow was great. And I had an interesting thing because he had already matched, so I had to take a year and be a junior attending. But it also gave me an opportunity to do a master's in clinical research before then doing his fellowship as a PGY8. It was a great experience. It was a lot of fun.
I mean, you're one of, it feels like hundreds of folks who have had some sort of like McAninch connection or McAninch mentorship. And I mean, even me as a former University of Washington fellowship from Dr. Wessels, from Dr. McAninch, I mean, it's...
You're a grandchild, yes.
Exactly. People just talk about him so fondly. Training under him must have been, I mean, I can't even imagine what it was like. It must have been so special.
It was special. He's just such a sweet and, well, he's brilliant, but he's just such a good person, such a high integrity person. I mean, I've had a lot of really incredible mentors here at UCSF and lean on all of them still, but spending that clinical year with Jack was really special. And then it led to me being hired and being his protege, which, those aren't shoes you can fill, but having him around, he's still working all these years, like 15 years later, it's been a blessing. It's been really awesome.
Yeah, no. I mean, as you know, here in Patel, your former fellow, my partner here at Ohio State talks about, him just kind of popping into the operating room and saying something really insightful and to be able to kind of teach at that level where you can see a case for 10 seconds or 30 seconds and like progress someone without touching the patient, I think is so cool.
Yeah, no, he's a special guy. Just had breakfast with him a couple weeks
wonderful.
ago.
Love it. How, you talk a little bit about being at UCSF for, the duration of your career then, and being under Dr. McAninch, and now, you yourself are a giant in reconstructive urology. How have you seen your practice evolve from the early career and kind of how he practiced to kind of how you're treating patients now?
Yeah, I think there's definitely been my practice is different than Jack's. When I took over, I was just starting and he was at the tail end of things. So I think we did get a little busier right away. And then I had the opportunity to inherit this big quaternary practice that he'd built for decades. And so got to care for all of his old patients. It had all the referral networks kind of built in. They knew that UCSF was a place to go for reconstructive care. I think one of the things that I'm interested in that he did less of is sexual medicine. So I do a fair bit of Peyronie's and surgical sexual dysfunction care, so implants. But pretty much do all the stuff that he did, dabble in the abdomen, do mostly kind of perineal surgeries, do a lot of cancer survivorship surgeries, prosthetics, do a ton of buried penis. In a lot of ways, the practice and what we do is similar, but in a lot of ways, it's really evolved and changed. I think we do far fewer anastomotic urethroplasties. I think we're doing probably a fewer buccal urethroplasties than I did, say, 10 years ago. In favor of non-transecting urethroplasties.
Mm-hmm.
Yeah.
Yeah, and that was one thing that I really wanted to get into as we kind of start to narrow down on urethral reconstruction, is how you've seen the process or you've seen the pathways change from Dr. Makinich to your procedures, and then how you've seen them change even over the course of time. So you feel like less, it seems like it kind of went in a anastomotic to buccal to back to anastomotic, but without a transection. Is that kind of what you're describing?
Mm-hmm. Yeah, I think that's accurate. I think for me, other evolutions in my practice have been around radiated patients. I'm definitely less aggressive with radiated strictures than I had been when I first, in those first 5 years. I still do urethroplasties, those membranous intraprostatic strictures that we find after radiation. But I tread, I think, more lightly, probably more aggressive in younger patients that have them, but just with high recurrence rates and I think sometimes less than satisfactory outcomes, tread lightly with those. Sometimes favored in the right patient doing a DVIU and having them dilate, but sometimes that's not an option. You have to, do plan B. The other, I think fossa strictures, Dmitry Nikolovsky's transurethral buccal procedure is just really awesome surgery that is, for any reconstructive person, very easy to learn and perform. That's a great surgery. The outcomes tend to be quite good, and you can actually do pretty long strictures with it. I think LS is another disease process that my viewpoint on it has changed over the last 15 years in practice. One where I tend to favor, if the patient's up for it, opening them up, then having them self-dilate with a steroid, as opposed to doing a big urethroplasty. Now, there's roles for big urethroplasties in those patients, and many of them need a meatoplasty at least. But those inflammatory strictures are just so prone to reforming. My use of the sort of triple, quadruple buccal, both sides of the mouth, fixing the whole thing, I still do those cases, but I think a little more sparingly.
Yeah. That was one thing I felt like Dr. Wessels kind of talked about the same progression. When I was in fellowship maybe 5 years after Niels Johnson, who's one of my mentors in residency, and even the strictures that he and I talked about fixing in fellowship were kind of very different. And I think that really reflected Dr. Volsky leaving the practice, and Dr. Wessels also kind of talking about making some of the shifts in kind of philosophy that you're talking about. We talked about, whereas I would look at a rug for a guy with LS and see two areas and say, I think we can get a buccal to go across both. I specifically remember the one that got us talking about this exact problem. And he was like, well, maybe we can do a meatoplasty or a Nikolovsky and then dilate the proximal one and kind of see if we can stop the proximal progression if we treat the meatus. It really was a different way of thinking than I think I expected even to come into, a year earlier when I transitioned from residency to fellowship.
Yeah, I think that's a fascinating aspect of stricture pathophysiology, is that sort of that distal stenosis that leads to the proximal disease. And it's this sort of, whether it's, 5-10 times a day the person's voiding, and there's this injury that happens every time they pee because they're having to push to get the pee through this tight little 3 French, 5 French area. The proximal tissue cracks and you get that squamous metaplasia transformation process. And with LS, you have this other sort of inflammatory component compounding the problem.
Absolutely. And I want to get into that a little bit later when we talk about urethroplasty research as well. But I did want to, before we lose the thought, I did want to ask you, you're describing kind of changes in your, and correct me if I'm wrong, kind of changes in your thought process and where you utilize different surgical approaches. But I did want to ask, are there surgical approaches that you just don't use anymore at all? Are there approaches that you've moved away from? Totally.
I think that's the cool thing about recon. It really is a toolbox. I will say that fasciocutaneous flaps, I just don't do them frequently. I do them maybe one every 2 years. Just rare for me to do them. I think they're a great case, and they are a little more technically demanding, and usually they go great and there's no problems. But when they go bad, it can be quite a bit of a disaster when the whole thing necroses. So with the advent of buccal, which is such a versatile graft material, I've really kind of gotten away from fasciocutaneous flaps. Besides that, though, I mean, most definitely still do anastomotics, excision, EPA. Most definitely do ventral, dorsal lateral buccals. Definitely do, I don't really do any dorsal, like really meatal cases. That's all ventral Nikolovsky approach, transurethral. That's actually, that changed the game for me, because you'd be dealing with fossa strictures that cross the corona, and approaching those dorsally and kind of trying to get that plane, as George, is a little treacherous as you're kind of getting into the fossa if you come from the shaft up. People I know Alex Vanny loves doing things dorsally at the tip there, and he gets great results. So it's technically, he's a very gifted surgeon. It's definitely something we can all do. I just found the ventral approach that Dimitri described to work quite well.
Yeah. I am a big fan of it as well. We didn't do any dorsal meatal cases in fellowship, so I don't know that I can speak about it with as much experience. But we always talked about, Judith Hagedorn and I always talked about, you do a Nikolovsky, and if you get in trouble, then you can kind of like do the Keith Rourke sliding T, where you've like major incision and you say, oh man, I outkicked my coverage, I cannot get the sutures down far enough. Well, then you can just open it up, do like a sliding T, and then close it back up. So that was kind of always our backup plan. I talk about it all the time with Hiran as he and I are deciding, what case to do where and that kind of thing. And I've never had to use it, but that's always my backup plan. We like that ventral approach too. Do you think that there are techniques, we're talking about your practice, but you're also, as you mentioned, you've got a degree in clinical research. I feel like whenever I want to catch up on what I've missed in urologic reconstructive research, I look at what your group is doing to kind of guide the PubMed search. As far as the national trends go, do you feel like there are techniques that are becoming over or underused nationally, within the GERS and reconstructive community?
It's a good question. I mean, I think sometimes I question the use of buccal urethroplasty for short strictures when you could do a non-transecting easily. I think at the end of the day, though, if the person's getting a good result, that's all that matters. And it's a toolbox. We all are comfortable with different things. And as long as you're getting a good outcome, the case isn't taking too long, and the patient doesn't suffer, bad side effects, oral side effects, et cetera, then I can't say that I think of any one procedure being used too much or too little.
This kind of gets to kind of your thoughts on your fellow and your fellow's case logs. As I was thinking about kind of things that you and I could talk about with Stricture, when I was a fellow, I asked Dr. Wessels about his case logs, and we actually tried to find some documentation of what he did with Dr. McAninch. And
Could he find him?
He didn't find it, but he kind of made some estimations for me. And one of them was, buccal urethroplasty. Yes, we're finding non-transecting techniques might, we may not need as much buccal as we used to, but I would still argue, and I think you probably would too, that buccal urethroplasty is still the workhorse much of urethroplasty, many urethroplasty techniques, I was going to say in the US, but I think worldwide it's pretty fair to say. But it was interesting to hear, I'm learning buccal urethroplasty from Dr. Wessels, who estimated that he had maybe done 10 to 15 during fellowship. And that's because buccal urethroplasty was relatively new when he was in fellowship. And I've never asked Dr. Wessels his age, and I won't, but it was not as common a technique as it is now. So I was wondering if you could talk about, as you talk about your philosophy on how you treat strictures, EPA to buccal to non-transecting for short strictures, for example, how you could think about your case logs versus your fellows' case logs and kind of, I'd love to hear you use that as a discussion of how urethroplasty is evolving.
Well, I agree the buccal is still the workhorse, but I would say in terms of how my practice has changed the most, we just did a lot more anastomotic urethroplasties when I was a fellow. And now, I don't know, 90% of those cases we circumferentially dissect around the urethra. We incise dorsally. We do a Heineke-Micklitz, non-transecting. I actually don't do any, if the plate is normal, and that's really the only time I'll do a non-transecting, I don't remove any of the mucosa and simply just do the incision and then a Heineke-Micklitz. And I've had, what I think are strong results. But, you're really taking advantage of the geometry of the urethra when you're doing a non-transecting urethroplasty. It's like an L. The bulbar urethra kind of goes into the GU diaphragm, becoming the membranous urethra, then the prostatic urethra, bladder neck. And you're taking advantage of that geometry at the angle of the L. And you use that geometry to cover distance. And Al Morey described this with posterior urethroplasties and being able to cover, doing an anastomotic and getting at least, doing 4 centimeters if you're able to take the fascia off the sponge. Well, and then, in the non-transecting, you're getting this angle there where you can really, if you're very proximal, you can do 4 centimeter strictures, no problem. However, as you get out of that proximal bulb into the mid bulb and then the distal bulb, once you get into that mid bulb, doing a non-transecting, when you're in that long part of the L, it gets harder and harder to bunch that tissue together without being concerned that maybe core D, or at least that it's not going to be tension free when they get an erection. So that's when in my practice, I'm really thinking about buccal. And, other considerations are sort of what the plate is like. Obviously, after a straddle injury, you're going to want to likely do an anastomotic. Certainly after PFUDs and these kind of things, that's when I'm doing anastomotics. Sometimes if it's a terrible radiated case and there's just a lot of horrible tissue there, we'll do an anastomotic. We'll also do non-transecting there. And then, of course, anything in the penis, you're really using buccal.
Yeah. One thought I had while you were kind of listing them off was, and you mentioned before, the way that you treat radiation may have changed over time. Are you doing buccal in some of those radiation strictures if you feel like you can get to it?
Yes, I've done that. And in general, I don't know if I love it, just because getting the apex of those all the way, when you're at the bladder neck practically, it's a little painful for me. But we've done them and we've had, I think, reasonable results. I think a lot of times you can cut away the tissue and still do a non-transecting successfully. Or if there's a bunch of necrotic tissue, probably makes sense. You could do an augmented roof, but probably just makes sense to cut out the bad stuff and then do an anastomotic. Those people, of course, will be totally incontinent and will need a sphincter. And so as much as you can spare the bulbar arteries, you should try to.
Absolutely. And as you talk about your kind of propensity to maybe get less aggressive with some of these really complex cases we're talking about from a surgical standpoint, like obviously they're still being managed, but you're maybe doing less invasive surgeries than the ones that have some higher recurrence rates. I wonder, do you feel like trainees, residents, and fellows really are seeing kind of more complex urethroplasties than they used to?
Yeah, I mean, I think part of we are training more reconstructive urologists. There are other endoscopic techniques that are evolving that are being widely disseminated. And I think as a consequence of that, some really kind of straightforward stuff. It's very, very unusual for me to see stuff that's super straightforward. It's usually, we get referred these cases that I definitely have seen it increasing in complexity over time. It's just very unusual for us to get a very straightforward case, although, we certainly get them. But it used to be more common that we would do, this is a 1 centimeter bulbar stricture, let's do an anastomotic, and it's a fun day. Those are less common.
Mm-hmm. Yeah, that I'm glad.
Is that your experience in Ohio?
I'm glad to hear you say it, because it's certainly it feels like that from my standpoint. But Dr. Patel and I, and now Dr. Walton, Eric Walton, our newest partner, part of it was also kind of, we wondered, are just the practice patterns and the referral patterns like not maybe as like manicured as someone who's had a longer practice, because we're also new. Are we only getting the ones where they're super complex because those are the patients that are out there that are now undergoing Optilooms, and maybe they're getting something transurethral first versus the new strictures? Or have we just not like manicured those referral patterns yet? So it's at least a little affirming to hear that you're also seeing that, because it sure does seem like things they're complex. They're like not the straightforward 2 centimeter non-instrumented bulbar urethroplasty anymore.
Yeah, well, maybe we're fixing all of the easy ones, and then it's just the hard ones that have recurred that are left. I some days I'm just like, wow, can I get a stricture that's not radiated or has lichen sclerosis? Like, is that possible? But
yeah,
I think that's part of the fun, is just figuring out a game plan of evolving over time and meeting the needs of the patients.
Yeah. I mean, to get slightly off topic, I certainly feel that way about my artificial urinary sphincters. I was talking to a friend of mine who's in private practice, and he was talking about, he wants to do sphincters, but he was deciding whether he was going to do the radiated ones or not. And I was like, when have you seen a non-radiated one? Like, that feel like they're all like that now.
I agree. Yeah. It's interesting how radiation contributes. I don't think we really give it enough credit in the sort of that disease process, because you'll have a guy that's going along with 1 pad a day, and then they need that adjuvant radiation, and they're now 5 pads a day. Or you have the guy that is doing great, then they radiate him, and then he gets a catheter, and the tissue's just totally fibrotic and terrible, and then they get floridly incontinent 10 pads a day.
Yeah. Or I mean, sometimes I feel like I hope for that for them, as opposed to like the urosynphyseal fistula.
Oh, totally.
Yeah.
Yeah, though those are devastating.
Yeah. They definitely are. We've talked about case longs. We're kind of getting into education a little bit, and education in reconstructive urology is something that I would love a career that focuses on. As someone who's been a longtime leader in GERS and the Society of Genitourinary Reconstructive Surgeons, could you talk a little bit about the role that urethral reconstruction is playing in fellows training, and maybe how that's changed over time with so many, like the expansion of the disease processes we see?
Yeah. And I just want to, throw kudos to you, George, because I do see you as a leader in the field and a rising star, and some of the, the work that you're doing in education and training around urethroplasty is really awesome. And we need young studs like you and women to come up and do incredible work, because the field's not going to move forward without people that want to do that stuff.
Well, I appreciate it. I'm going to send this episode to my parents now.
Well, to answer your question, it's like urethroplasty is sort of that central thing that kind of we self-identify with in GERS. And it's fascinating. The GERS field is so fascinating to me. And I've been lucky to be around the folks and to be a part of conversations about where the field is going and how the field has evolved. I love that we're such an inclusive community and one that like really, the tent is huge and it's growing. Transgender, transitional, cancer survivorship, Peyronie's, robotics, the list goes on and on. I'm sure I missed thinking about a couple things, but and all the skin stuff that we do, buried penis, etc. I think central to all of it really is quality of life, although you probably do, and I know I do a fair bit of it when it comes through penile cancer and using reconstructive techniques to help men with penile cancer. This change has been reflected in our case logs for fellowship programs. And, Keith Rourke did a really incredible job leading this. Keith is now a longtime urologist in Alberta, now at UC Irvine, just an incredibly gifted surgeon and a great person. The field has really evolved to the point where our fellowships now, instead of you have to get like 100 urethroplasties, I think the total now is 60, but there's like 4 different domains, and you have to be at least strong to have a fellowship in 2 of those domains. They're, cancer survivorship, prosthetics, penile cases, can't remember all of them, but I think those changes reflect how our field's evolving and reflect how there's not one way to define us. We're not defined by one case. We're not defined by urethra. I think urethra is still sort of core to what we do. And I think when you define what a fellowship in GERS is, I think that's sort of the glue. But in the future, maybe that comes under debate. I don't know. And, hopefully we figure out urethral stricture and get away with, don't ever have to do urethroplasties, right? But it's still one of the more common cases that we do. But if you look at anybody's practice, everybody's practice is a little different in what they're focusing on. Some people are doing more abdominal cases. Some people are, doing more prosthetics. Some people are doing more skin things. So it's really variable.
Yeah.
What's your perspective?
I mean, I certainly, this is a, disclosure, this is a podcast on urethral strictures, and I do think that urethral stricture is still kind of the campfire. It's what you have to be kind of a master of the perineum to be a reconstructive urologist, I think. And we're still the ones in some cases who, in those penile cancer cases, get called to help with the, urethral dissection, or, certainly in like the trauma cases, like we're the folks who often get called on to help with like perineal and pelvic injuries. So I certainly think that perineal surgery and urethral surgery specifically, like I said, is still like the campfire that we all kind of come to a couple of times a year, but we come into it from different places and different perspectives. You name a reconstructive urologist, and at least from an outside perspective, I would tell you like what my thoughts are on their like clinical focus and clinical volume, mostly based on kind of what they publish and what they talk about. But there's a bunch of them, like you said, like gender surgery, robotic surgery, transitional urology, who does lots of abdominal stuff, who does the skin and soft tissue stuff. I think it's like really wonderful. And when I talk about with our residents who are hopefully all listening to this podcast and all thinking about reconstructive urology, I talk about like, I love the fact that oftentimes I get problems that like maybe aren't represented on the case logs, or you can't say, oh, this is that case. It's like a bunch of different cases, and I kind of have to put it together. Or, I talked with Rachel Mann about, I think one of the coolest things about reconstructive urology is that you may train in one place, then you get a job somewhere else, and those just aren't the patients you see. It's really like your disease processes and your patients that kind of guide what you end up being an expert in and being a reconstructive urologist to treat. I also like love that and the creativity that kind of goes into it.
Well, back to the campfire analogy, we got to go camping sometime because I love to camp. I take my 3 kids camping all the time. We try to do like in COVID, we were going every month, and I was like dad of the year. Now I'm I've slipped off my game, and sometimes sleeping in the tent on the ground kills my next day. But camping is so fun. I love camping. I love getting outdoors.
Yeah. Well, I think that, and maybe it's some sort of Venn diagram and like the personality of a reconstructive urologist, but you see Dr. Myers like on his hikes and all the time as well,
He's the man. He really goes on these incredible adventures with his kids and with his friends, and looking at some of his pictures, like you're like, wow. In Utah is just such a gorgeous state with so many beautiful places to do that. But yeah, he's truly backwoods. He's the real deal.
But maybe there's some sort of camping thing. Maybe the next GERS shouldn't be in a major city, but it should be like,
why have a ski meeting? We got to do a camp meeting.
Exactly.
George, what an idea.
That would be fun. I'm already worried that you're gonna next like tap me to organize it. But it would certainly be fun to go to. So one thing that is something that I struggle with and think about a lot as we talk about, the complexity of cases and what constitutes reconstruction. And I always go back to, for us urologists in general, the AUA, I've heard the stat that like 65% of counties in the US don't have a urologist. There's a shortage of urologists. We're training more reconstructive urologists than we used to. There are 30 fellowships where there used to be 12, but we're still short on reconstructive urologists. So I'm always thinking when I'm teaching some of these techniques, and especially urethroplasty, like, I think I can get my chief residents to be able to graduate being able to do a urethroplasty, which I know is a controversial thought. Like, is it a subspecialty case? Is a straightforward EPA or bulbar urethroplasty? Like, is that something that a private practice urologist or a non-subspecialty trained urologist should be doing for patients, or should they be referring them? The guidelines, they are, I think, generously, they say that, people doing urethroplasty should be able to do urethroplasty and comfortable with urethroplasty. I don't think they necessarily say we have to be subspecialty trained. So I'm rambling a little bit, but I'd love your thoughts on like where residents factor into the more of these complex cases, and if urethral reconstruction is something that they should be exposed to, or should they be working towards competency, or is it somewhere in the middle? I'd love your thoughts on it.
Yeah, I think it just depends on the person and the aptitude and the interest. And I do think that someone can do a urethroplasty without specialty training, although the specialty training really, really helps. Just getting in those reps and seeing it and doing it for a year at a high level. But a straightforward case, if someone's had a lot of experience as a resident and they're a good surgeon, absolutely they can do that. You may not have been in practice long enough to have experienced this, but I've definitely gotten referrals from probably things that a person maybe shouldn't have taken on, or they did something that I think is pretty out of bounds. And I think you see that probably in any kind of subdiscipline. It's not just specific to urethra. It just may be a mistake, or the person, maybe got in front of their skis, or however you want to think about it. But I agree with you, though. There's so much to be learned from at least doing those cases as a resident. It's on for our residents, a main prime time for them to develop their dexterity for open surgery.
Mm-hmm. Yeah.
Not tying, dissecting tissues, countertraction, exposure, just those core principles. Because we do so much endo and so much robotics, you get a little less of that. And so I think, at least in our program, that's a good time for them to get some exposure to that. But yeah, the more exotic the urethroplasty gets, obviously, and that's one of the tough things about urethral reconstruction is that you the rug is fine, great, okay, scope them, sure. I think you have a good sense for what you're getting into. But like even yesterday, I did a case where I was a little bit deceived by the rug, and it turned out to basically be a membranous stricture, a short membranous stricture in a heavy guy. Yeah, BMI probably like 38 or something along. Maybe that's like for you guys, like
in Ohio, I'd love some 38s.
Teasing, but yeah, so like all of a sudden we're in there, and he's youngish, and so his good vasculature. It's not dry. And all of a sudden you're like, okay, we're doing a case here. And it wasn't exactly the case that I had envisioned. And so if you don't have exposure to that, if you don't have the experience, I think sometimes that kind of thing it could be hard for someone in practice to manage that or even want to manage that.
Yeah, that's a good point. And kind of being able to troubleshoot, I think, is the difference between doing a straightforward case and maybe like outkicking your coverage is like, all of a sudden this case ended up being very different than what I thought it was going to be. And I've already passed a point where we now have to complete the anastomosis, like this has to be done.
I think in terms of, you're right, we have a shortage. I think the fact that we're training so many reconstructive urologists really is helping. I also think, Optilume is something that's helped. How much, I'm not sure, but I do think, the guideline basically says refer to someone who has experience, who does urethroplasty.
Yeah.
And I think that's fair, but if you're someone that's training in residency and you're going to be out in general practice and you don't have a partner that does it, or you're in a rural community and you feel comfortable, like I would definitely go for it. But I also know that there are all of these centers now that have 3, 4, 5 reconstructive urologists that can help.
Yeah. 3 in just the last 18 months for us.
It's incredible.
Yeah. It is certainly growing, and the increase in fellowships, I mean, that certainly has helped. But that is, the thought that I kind of always have when I'm looking at the resident that's operating with me is like, do I think I can get this person to the point where they could do, what we're doing today? As you're doing that, and your practice is obviously different than mine, both in your experience and you have a fellow kind of taking on, I'm sure, some of the teaching burden, even while they're also learning. But I wonder, like, do you have a curriculum that you follow? Do you have or just a sense for kind of who should be doing what at what level? That's one thing that I'm trying to look into and would love to look into on a national level, but kind of understanding, for someone who's been teaching urethral reconstruction for a long time, like when you get a PGY2 versus a PGY5, do you have specific things where you're like, I never let X person do this, or you should definitely be doing that kind of thing?
You're right. It's specific to level, where you are in training, and it's also specific to your inherent, I think, hands and ability, and where you are in your kind of journey of becoming a surgeon and an independent surgeon, I should say. And that's something I think I rely a little, maybe too much, but I rely on intuition and just gut and seeing, and I'll let them do as much as that looks good. And then, if I'm having them tie the 5-0 PDS and there's a bunch of problems or the hands aren't there yet, I'll probably end up doing the tying for most of the case then, and then coach them on how to improve those skills. We have this, it's super fun to see, but typically I work with a 3 and a 4. So you'll be with me for a month in your 3rd year and then 2 months in your 4th year. And it's awesome to see the improvement that folks have. And it's awesome for them to come back and have doing pretty much the same case. Although, that's the fun part about reconstruction, is 'cause it's all a little different, but basically the same case. And so then they know the steps, they're very comfortable. The fellow plays such an important role in teaching and supporting us get things done, and they're there. So I think I base it on how the hands are, where they are with their development of surgical technique, and then their experience with me to date, and kind of what, some of it also has to do with like, well, maybe there's no fellow that day and we have 4 of the same case. Okay, you're going to do more because you've seen a bunch in rapid fire. I'm going to kind of like, okay, dissect around this urethra, put these stitches in, etc.
There are still academic programs who don't have a reconstructionist. Are there GERS resources or AUA resources, or kind of how would you recommend those folks get some perineal or urethral experience?
There is a GERS program that allows folks that don't have a GERS person, to residents, to get some training at an institution that does. And this is both for international folks and for people in the States and Canada. And so I'd encourage them to look on the website and apply to that. Dmitry Nikolovsky is the secretary of GERS now, and he could be a point person if someone is interested in that. We host folks all the time from programs that don't have recon because the person's interested and they want to see it. And actually have matched a fellow who did a month with us as a resident. And then, we loved him and he loved us, so we had him as a fellow. I think if you're a resident and you're interested in recon and you don't have someone at your institution, I think there's two things that you should do. One is, talk to your program director, see if it's possible to do an elective with someone in the field, and then write them, reach out. I think most institutions would be welcoming. So if there's something logistically that's easier for you, pick a high volume place that's in your region and try to get some exposure. And then the other thing is to try to do some research in the area. So if you're anticipating wanting to do a fellowship, I think that does make you a little more of a competitive applicant if you've shown some interest in reconstructive urology and you do some things. I mean, like, you were an incredibly competitive fellow and you had done at Vanderbilt a bunch of...
Yeah, and Niels was a big advantage for me.
Yeah. So, you were the belle of the ball, and I think it helps. So if you're a resident, you don't have that kind of person at your program to teach you or train you, don't see that as a total kind of, you can't get in. You just need to do a little extra legwork to get to have those opportunities.
Yeah. And I will say that kind of, and maybe it's post-COVID and maybe this always existed and I'm just now getting wind of it, but I do feel like there are more and more like collaborative efforts, whether it's attendings at different institutions or even like residents working with an attending that is not at their institution. I do feel like maybe, and again, maybe I just missed it before, but a lot of reconstructive collaborative efforts, and more recently maybe. Another really interesting kind of aspect of urethral reconstruction, and we've danced around it a little bit so far, is talking about kind of real world practice and guideline adherence and kind of where those gaps are for urethral reconstruction in places that may not have a reconstructionist. And I was wondering, outside of just increasing the number of fellows, if we could talk about ways to improve access for urethral reconstruction patients. I thought was interesting.
I mean, for us, telehealth is amazing. And, people can get second opinions, people can get their case reviewed, but many don't have the resources to sort of get on a plane and get to Columbus, Ohio, or come to San Francisco. So how do those people get treated? I mean, I really do think there has been an explosion. If you can imagine when Dr. Wessels did his fellowship, how many reconstructive urologists there were kind of doing these things. So I do think over the last 20, 30 years, there's been a vanguard of folks that are interested in this work, who are committed to these patients in this disease state. So that's had a huge impact. Beyond trying to get to a center where there's expertise, there is a problem, with just getting urologic care, period. General, subspecialty, quaternary, tertiary, when you're in a rural community. It's just one of the things about it. It's the urologists in the rural community. We wrote a paper on this. They're older, they're retiring, and it's very, very tough for folks in the rural communities to get access. The urologists that remain in those communities are just inundated. I mean, they are so busy, and I hear these stories from my folks. Hey, I can't see my guy because he's next availables, 6 months from now. And I know these guys are just working their tails off night and day to try to service their community. I don't know the answer to that. I mean, we need to figure out how to incentivize subspecialists to be in the rural communities. I'm assuming that's the answer, but I don't know what your perspective is.
I have a similar one. I think that when I've talked to some of our like referring urologists or folks that will like, reach out with a specific problem patient, I mean, man, they seem really, really overburdened. And I think you're right. I mean, it's got to be some sort of incentive program, I think early on at least, because if you want work, there's no shortage of it. And I think that for a subspecialist who's just come out of fellowship, who, wants to do their subspecialty, I think the first, I feel like 18 months of my practice, I mean, we always talk about drinking like a fire hose from like intern year on, or even as a medical student. I feel like it's like that now, I feel like I'm learning so much, what to do, what not to do, what I should have done, what I shouldn't have done. And then I'm lucky to have, a couple of partners who support me, and reconstructive partners, and then a whole department of folks who are really supportive. But when you come out of fellowship and that's what you want to do is that subspecialty care, if you open a rural practice, you're going to see absolutely everything because they need a urologist. So there will have to be some way to figure out how to kind of, maybe it's a group hire or pool hire where it's, a rural place is going to say, okay, we're going to invest not only in bringing a GERS person, but we're going to get a GERS person, oncologist, a general urologist, and a stone guy, and we're going to group hire them or something like that, And now we're saying that there's a shortage of urologists, and I'm just saying you gotta hire 4 at once. But it's going to have to be something like that, because from a subspecialty standpoint, I feel like I've learned so much because I'm at a big quaternary center. I see tons of recon, but it will be harder to pull a fellow who's so excited about starting their career as a reconstructionist to then go to a rural area and maybe have to see a bunch of elevated PSA, or maybe have to see a bunch of, BPH LUTs. So it'll have to be incentive, but I think it'll have to be some sort of creative solution too.
Yeah, I don't know the answer, but
yeah,
it's definitely a challenge.
Mm-hmm.
I do think telehealth has helped. You still have to come down here for surgery, and
Yeah, I mean, for surgery, even if you're saying we'll sheet your rug on the day of surgery or the day before or something like that, it's still like, to get a rug, to get a Uroflow, to cysto somebody, you're probably talking about multiple visits, unless you have a local urologist that really, really trust their workup, and they have a track record of like communicating things with you and that kind of thing. Dr. Wessel's had a great system and a great practice where like there were a bunch of urologists in Alaska who he's been working with for a long time, lots of more UW graduates, and they would come down, and we used to call it one-stop shop, where like they would come down, and in one trip to Seattle, they would get like all of their stuff done in a week period, and you like rarely got burned because they had they knew what he was looking for, and he knew that they would have what he was looking for, and it was a good system. But you got to that's time and relationships to build that kind of thing.
Yeah.
Last thing, I know I've already asked you to solve the education and access issues in urethral surgery already today. But one thing that you really are a leader in is reconstructive urologic research. I was wondering if you could talk about how you've seen the research space in reconstructive urology and, grow and change kind of over time.
Yeah, it's been a really cool thing to see and in a small way be a part of. Coming up, it was really case series describing techniques. And I think a lot of things have been refined, including sort of just in many ways describing the patient experience. So patient-reported outcome measures, defining success in urethral reconstruction, and understanding it's more complicated than just the pipe is open. Just looking at the landscape, there more usage of sort of big data sets, whether that's Medicare or market scan, employing epidemiology and clinical research techniques. People across the world have gotten more sophisticated with access to data and software suites to analyze these things. And more interest in the basic science of urethral stricture and also trials related to different therapeutics, which I think we're still lacking. And, I think that's a growth area.
Yeah, that's one thing. When I started being interested in reconstructive urology as a resident and starting to think about projects with Dr. Johnson, with Dr. Kaufman, like thinking about where the oncology space is and where the reconstructive urology space is from a research standpoint, and thinking about how different they are, but maybe also how we could model some of what we do in recon versus what they were already doing in oncology from a research standpoint, I think was kind of always the thing that I used to try to figure out how we were going to do, XYZ project.
If we have time, I want to tell a quick story. I think it was the San Diego AUA, and I think I was a junior attending, and walking out of the session, and I saw Peter Carroll, who's my boss, my chair, and he's been a very instrumental and close mentor for the past 25 years. And I was pretty energized, thought, wow, this is really cool, like all these people together talking about science. And Peter was walking in, he was very disappointed in the quality of the science that he had just seen at the session. And he was like, I can't, this is just, the field's not going anywhere. I think kind of with that lens of, I feel like we've come a long way, but we've also sort of not. And I do think that there's a lot that recon, in terms of sort of rigor, I don't think that there's quite the same investment from grants and from industry that obviously cancer has. The quality of the research that's being done in recon, not to, because I do it, not to poo-poo it, but it's definitely a step below cancer. And I think, there's a lot for us to get better at. There's a lot for us to kind of sink our teeth into, other than, hey, look at this big data set that I analyzed and found this association, or this is, a collaborative 40 cases of this procedure, it works pretty well. Like those things are incremental and I think helpful. And I've done a bunch of that stuff, but we really got to get to the big questions. And I think, we can get into Optilume. What excites me about that is just the concept of medicine applied to a stricture. I don't know if paclitaxel is the right medicine, but what I would love to see are companies using all these different molecules. Maybe it's AI that we find the next perfect molecule. Can we do it associated with disease state? Can you have an LS balloon or this is for radiation? Like these are different milieus. They're not the same.
Yeah, no, I thinking about the same thing, and this is an idea that I would love if someone would scoop, because it's I think a cool idea, but I don't know that I'm the urologist to do it. But I would love, Coloplast has hydrophilic coatings, and I was talking to Dr. Wessels a bunch about, hey, it would be great if we could, we cysto lots of our strictures prior to treatment, right? Sometimes it's just a rug, but oftentimes we have a cysto too. And what if we could like get a biopsy, and then we had a hydrophilic balloon, and we said, oh, like this is the medication for this stricture, this is the medication for that stricture. You just need one device, and you could, do some sort of, med soak, just like we do for, some people do with their implants, based on culture or based on antibiogram for their institution. You could do the same thing for stricture and pathology. I've always thought that would be a really cool idea. But you're right, the money's got to be there from industry or from the NIH or from philanthropy, wherever it comes from. And it is, I think reconstructive urology sometimes might be a harder space to find funding for.
Yeah, I agree.
Yeah. One place where, I think that maybe, if we're going to use urologic oncology as like our model for what we could potentially do for research ideas in the future, kind of jumping on their back a little bit as far as, focusing on the cancer survivorship aspect of some of the things that we do, and then maybe extrapolating that to the more benign processes, I think could be certainly one where we could leverage some things like funding. But we're certainly behind urologic oncology, I think, in kind of the landscape overall. I'd love to know, what unanswered questions do you think that we need to tackle in the next decade?
I think we just don't have a full comprehension of why strictures form and how to best treat them. I think that Urethroplasty is a highly successful surgery. It's not perfect. People get through it relatively smoothly, but it's not a total walk in the park for everybody. I do think some of the work done by Brad Erickson through the Turns group around phenotyping strictures so that we can have, I think criticism of it's maybe overly complicated. But what I really like about it is that you can have an apples to apples comparison and discussions, at least in the setting of an academic meeting or in the setting of a clinical trial or a paper.
Mm-hmm.
Because not every stricture is the same, and not every bulbar stricture is the same. And when you really dig into the weeds, and Brad did, it's actually quite nuanced and complicated. But I think having that as a footing will help us better understand pathophysiology, because we can actually talk about things cogently. I love this idea of, minimally invasive. Nick Warner's a real innovator at Mayo doing these minimally invasive techniques. I do think, besides pathophysiology and potentially medicines, there's going to be instrumentation and different technical things that are produced. There are innovators out there that are testing things and thinking about things.
Mm-hmm.
I think that's a super exciting space, doing these transurethral buckles in the bulb, the bladder neck surgeries that he's doing, that's all very cool. So I think that there's still room for technologic improvements. And personally, I'm, also love to continue to see the patient's voice in research. We've created a patient reported outcome measure, USIM, for urethral strictures. And I think, really understanding the impact that the surgery has on the patient across domains that are important to them.
Mm-hmm.
Truly, if we really are concerned about success and the impacts of different therapies, that's an important thing that we have to kind of focus on.
Yeah, absolutely. And, brings you back to the whole reason you got into reconstructive urology, quality of life, patient voice.
Yeah, for sure. And recon is a really cool field. I'm always excited and energized when, if there's a resident that's interested in it, mm-hmm. or, talking with the fellows that are going into it. I think it's a great field, and it's
mm-hmm.
only growing.
Yeah, absolutely. Thank you so much for joining me today on BackTable Urology, Dr. Breyer. You're a force in urologic reconstruction. I loved our talking shop. I hope I didn't take up too much time. I know you're a busy guy, but thank you so much for joining. This was really wonderful.
Thank you, George. Thank you for the opportunity. I'm super grateful. It was super fun to talk with you as well and get to know you better.
Yeah, absolutely.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.